treatment for hepatocellular carcinoma was TACE, which is the trans-arterial chemoembolization, right? But in the recent years, we have seen that over the past 10 years, actually, so this is still relatively new concept that the company faced with the immune checkpoint inhibitors, such as the one that we studied in particular was Camrelizumab, but there are many others. For example, levetiracetam, which is also being discussed in the study. So they have a synergistic effect when used together along with this. So how this works is that when you compare the efficacy and the safety of these two drugs, they have a very significant anti-tumor activity, and they also have a durable response, and they help in a long-term survival of over 2 years as compared to TACE alone. The design, which is the methodology, so it followed the PRISMA 2020 guidelines, where it's a systematic review and a meta-analysis where we ran a search on PubMed, Google Scholar, and and Cochrane Central Registries for the randomized control trials, which covered liver HCC, which is hepatocellular carcinoma, immune checkpoint inhibitors, and camrelizumab. So the paper also has a detailed search strategy. And then after that, we identified around 1,023 records. And then we removed the duplicates because some of the records were duplicate on each platform. And we excluded the records which were not speaking about our topic or related to our interest. And we shortlisted 6 articles which were included in the study to perform a meta-analysis on. And we've also provided a quality assessment of the studies that we have talked about. Why we chose camrelizumab in general is because there's been no other studies which have targeted this drug. The most common drugs that have been studied previously in previous studies are safratinib, levatinib, and safratinib, levatinib, and tocilizumab. All of these have have studied, but this drug has not been studied. And when we did our research, we found that the frequency of serious adverse effects or SAEs is very less in this drug. The most common were rash, which was seen in around 27.1% of our patients, hypertension in 18.6, fatigue in 17.1, diarrhea in 17.1, and paresthesia in 15.7, and nausea also in 15.7. So the side effects, if any, are quite mild as compared to the other drugs. The studies that were included were the randomized control trials. We included randomized control trials in our study. So we combined 288 patients from our 6 studies, and we were looking at the complete response rate, which is no tumor as per, or a partial response rate, which is response to the therapy, and also how many percentage of our patients had stable disease, the objective response rate, and the progression-free survival. The progression-free survival for our study was 6.2 months, which is no tumor for 6.2 months, 2 months to put it simply. And the complete response rate was 7.35% in our study, and the partial response rate was observed in 37.1% of patients. From the 288 patients that we studied, we saw that the complete response rate was 7.35%, and the partial response rate was observed in 37.1% of patients. 28.7% of patients had stable disease, and the objective response rate was found to be 46.13%. The disease control rate was 77.1%, and the progression-free survival was 6.2 months, like I mentioned. So overall, to sum it up, we can see that definitely camrelizumab is an efficacious drug to be combined with TACE to treat hepatocellular carcinoma. Coming to the toxicity, so we didn't do the study on toxicity, but we did reference other studies which have done the toxicity on other immune checkpoint inhibitors. And from our own research, we found that this, as compared to sorafenib or levetiracetam, which were the previous studies drugs, camrelizumab has a much less risk of serious adverse effects. Treatment approach. There are many factors which could affect this. The tumor staging, the markers, the patient's this and all of that. So, I think one conclusion that we have reached over the past 10 years is that TACE alone is not as effective for any tumor above more than 5 centimeter, any lesion more than 5 centimeter. And we should think about combining, physicians should think about combining TACE with either an immune checkpoint inhibitor or even radio frequency ablation and microwave ablation. These are also alternate treatment approaches. So I think the endpoint here is to do a combination approach of TACE and other treatments for any lesion more than 5 centimeter. And we definitely need more studies done on more drugs and also a larger sample size of population because we considered only 6 studies in our research paper, but we need more studies, more control trials, more drugs to be, more immune checkpoint inhibitors to be studied to actually figure out which is the most efficacious as well as safe drug. Because some of the other drugs, for example, sorafenib, have reported quite serious adverse effects, so they would be efficacious but not safe. I think one thing that we could talk about is the time of when the taste should be given along with like in what stage of the tumor. So there's a paper cited which speaks about microwave frequency ablation as well as radio frequency ablation. And I think it's very important to study the patient individually and localize the tumor size, know the tumor size, and whether it's local or it has metastasized, and then go for treatment.